Good afternoon, everyone. It's Sandy Dunn from Bourne, Ontario. Welcome to today's Bourne Provincial Rounds. I have the pleasure of introducing Dr. Ivy Bourgault, who will be today's speaker. The title of her presentation is MSH-CARES, Evaluation and Scaling Up of a Multifaceted Intervention to Reduce Cesarean Section Rates in a Community Hospital Setting. Just for clarification, MSH stands for Markham Stouffville Hospital, and the CARES component of the acronym stands for Cesarean Section Reduction Strategy, and Ivy will be going through more description of the initiative that has been put in place at Markham Stouffville. Before we get to the talk, though, it gives me great pleasure to tell you a little bit about our speaker. Ivy Bourgault is professor at the Faculty of Health Sciences at the University of Ottawa. She's also the scientific director of the recently established Pan-Ontario Population Health Improvement Research Network and the Ontario Health Human Resource Research Network, both housed at the University of Ottawa with funding from the Ontario Ministry of Health and Long-Term Care. Ivy is the Canadian Institute of Health Research Chair in Health Human Resource Policy, which is jointly funded by the Federal Ministry of Health Canada. And she's also just recently been named, received a CIHR chair in gender work and health. Dr. Bourgault has published widely in national and international journals and edited volumes on midwifery and maternity care, primary care delivery, advanced practice nursing, qualitative health research methods, and on complementary and alternative medicine. And Ivy is also a member of the recently established Health Quality Ontario expert panel about cesarean section. So today's topic is very apropos of the work that that committee is looking for or working on. So just before I pass the mic over to Ivy, just to verify with you, we will let Ivy go through her slides just for simplicity in getting the information presented, and then have a question-answer period following her presentation. So if you have questions as you listen to her presentation, you can type them in the chat box on your screen, and we will scroll through the questions after Ivy has finished. Also, one last note, just to verify, we will be recording this session, and the slides and the webinar will be posted on the Bourne website for future use by people who perhaps haven't had the opportunity to join us today. So without further ado then, it's my pleasure to introduce Ivy Bourgault and pass the mic over to her for her presentation.
Excellent. Thank you very much. So I just want to confirm that, Sandy, you can tell me you can hear me well enough?
Yep, you sound fine to us, Ivy.
Great, super. So thank you so much for that generous introduction. I really appreciate it, and I'm really looking forward to doing this presentation and getting feedback from the broader community, Bourne community. As Andy described, we're looking at this cesarean section reduction strategy initially at Markham Stouffville Hospital, and we're also very excited about working also with Queensway Carleton Hospital. They're very interested in adopting components of this intervention or innovative intervention, and we're very keen to talk to other hospitals who might be interested in incorporating elements of the intervention. So I'm going to ask just for the slide to be advanced because my computer's acting a little bit slow. So I just want to acknowledge Danielle Rolfe and Esther Schumacher here at the University of Ottawa. Danielle is a postdoctoral fellow and Esther's a doctoral fellow, and they've been intricately involved in coordinating this project. And I will have their email address at the end if you would like more information about it. They're more sort of day-to-day hands-on with the project. Carol Cameron initially contacted me from Markham Stouffville Hospital. She, at the time, was the head midwife, but now she's the director of the entire unit. Joanne McKenzie was working with her. She is now at Mount Sinai. But also Carolyn Harris, who's our sort of research coordinator at Markham Stouffville Hospital, and George Arnold, who's the chief OB. Colleagues Eileen Hutton, Elena Niederman, Rishma Walji, who are all at McMaster, and acknowledgments to Sandy, who has been a very important linker and connector, knowledge translator between the work that we're doing at Markham Stouffville Hospital and Queensway Carleton. And there we have specifically been working with Melissa Doherty, Sally Dobranowicz, and Lisa Honey, who's the head of OB. I will acknowledge also that we have received funding from CIHR initially through a planning grant with the Partnership for Health System Improvement program, and we also received some bridging funds through the Open Operating Grant program. But we still have another funding proposal in submission to do the broader study that we'll be outlining today. So just to the next slide, we'll go through in terms of the objectives, just to give you a sense as to what we'll be going through. It's to provide some background and context related to the strategy at Markham Stouffville Hospital, and to describe those components and some very preliminary results just based on the administrative data that they have at the hospital. And but we're really trying to kind of dig a bit more deeply into doing much more sophisticated analyses with the findings, controlling for a variety of other factors that we have not been able to with the very raw administrative data that they have, but there's some very promising preliminary data. And then to talk about our planned evaluation and some of the results that we are getting to date, not only in terms of the evaluation at Markham Stouffville Hospital, but also the scale up specifically to Queensway Carleton. So just the next slide is just linking us into the MSHCARES study, so we can actually click twice and get into the background in terms of the development. And I'm hoping that this is not going slowly because of my computer, but thank you. So the development of the MSH-CARES initiative, I think this is really important, and I'm hoping that this might resonate with some other hospitals. And just even reflecting on some of the work that we're doing with the expert advisory panel is trying to ask whether or not, is there a creeping up of the C-section rates? Is that consistent across hospitals? And what's the kind of variation that we have? So specifically at Markham Stouffville Hospital, they had noted that their C-section rate was inching up. It was initially 25% in 2005, and then in their fiscal year 9-10, it was edging up to the 30%, so it was 29.7. And they had also identified that there were inductions happening that were what they would refer to as inappropriate. They were happening too early, so women were being booked in their 39th week, and so there wasn't the waiting until 41 in 3 days as was recommended by clinical practice guidelines. They had also noticed that very few women were choosing vaginal birth after cesarean sections, despite there being a high success rate if a trial of labor was attempted. Now, and you need to also put that within the broader context of the hospital, that their annual birth volumes were increasing. So they were looking at moving from 3,000 births to projecting upwards of 4,000 births. But the hospital had identified, some of the pictures along the side there note the construction that they were doing. They had acknowledged that there was going to be an increase in birth volume, but they wanted to acknowledge that there wasn't going to be an increase in funding, and that if there was going to be this continual increase in C-sections, that they would have to reduce their birth volumes, or they would have to cap the birth volumes because there simply wasn't an increase in funding. And it wasn't so much the costs for C-sections from OHIP for the physicians, but it was the cost of the additional hospital budgetary costs for C-sections. And when we had conversations with folks at Markham Stouffville Hospital, they were also commenting on, even the gels for the inductions were, adding up in costs. And just, so there was a variety of different factors involved. So the next slide was just talking about the, an interdisciplinary task force that they brought together in August of 2010, and it was around about this time that Carol Cameron had contacted me in regards to, we're doing some interesting stuff at Markham Stouffville Hospital. Are you interested in being involved? And we were. So this task force was interdisciplinary, so everybody, as they say, had skin in the game. And so they wanted to look at, they wanted to develop an evidence-based method for addressing the issues around C-sections and set some performance targets. And when we do this presentation in tandem with Carol, she has identified why were these particular targets chosen. It's just because that they felt that they were doable. So their C-section rate was 25% before, and they felt that they could bring it back down to 25%. So it was just identified as something that was doable that they could achieve. They wanted to decrease the labor induction rate in general to 22%. They wanted to bring the inappropriate labor induction rate, so labor induction for post-states prior to 41 weeks. They wanted to bring that down to 0, but in the general labor induction rate, they wanted to bring down to 22%, and they wanted to increase their VBAC rate to 25%. And on the next slide, we just provide a bit of an overview of the targets that they wanted to achieve and the different elements of the program that they were working on. And so they will. I'll just as soon as this comes available. Great. So the parts in Peach are just so they wanted to intervene in terms of the induction and VBAC rate. They wanted to target health professional factors as well as issues about the patients and the public, so maternal factors. And so these are all the factors, fetal factors, that all link into C-sections. And there are some elements of the intervention, which are in blue, which are targeting the different levels. So we'll go through each of those in turn, but just to describe, at the maternal level, there was a public education campaign specifically for women who had previous C-sections. There was a birth option session, so to provide some counseling in regards to making the decision as to choose another C-section or to choose a trial of labor. They had changed their VBAC policy to encourage all women who were eligible to attend the birth option sessions. They shifted to be much more strict about their post-state induction policy. And then in terms of providers, they were providing peer and self-rater feedback. So the next slide, we'll start to get into the patient education strategy. So as we mentioned, the first element of that was a public education campaign. And they really wanted to increase the awareness of the strategy, this multiple intervention strategy, interdisciplinary strategy, at the hospital and at the maternity care unit. And so they termed this pushing for the best choice. So here's an example of one of the posters that they presented at one of the open houses. And then they also created some posters that exist on the unit. So this particular poster, if you see, there are rates for September that you might see at sort of the bottom right-hand side of the slide. So this is a poster that they have right at the entrance to the birthing unit. So it's very clear that they make it known to the public that they are trying to reduce their C-section rate and their induction rate. So they make those known for the period of time that they're looking at. And so they really want to increase that. The next slide focuses on a poster that they have throughout the hospital, and it was also an ad that they had in the local paper. So again, pushing for the best choice. Like you, your birth experience will be unique for you and your family. Did you know that many women can safely and successfully deliver their babies normally even after having a previous C-section? And then speak with your healthcare provider about that. And the other element of this includes the birth option information sessions that I mentioned before, providing counseling to women using a variety of different decision aids for them to make very clear and informed decisions about whether or not they feel comfortable and confident to do a trial of labor. So the next slide moves into the provider strategy, so some of the elements of the intervention that targeted providers. And there, this was, again, you need to have your opinion leader. So the chief of obstetrics, George Arnold, updated clinicians at the start of the strategy. Here are what our baseline rates are. Here are what our targets. And everybody had skin in the game. So all clinicians have a C-section rate. So even the midwives, although the midwives don't do the C-section, when they transfer the care of their clients, they will essentially, quote unquote, own the C-section rate for those clients, so that everybody has skin in the game. And that was initially released to them blinded for the first 3 months, and then they all collectively decided by consensus that they would unblind those amongst their peers. So although on the poster that we talked about, they have the overall C-section rate for the unit, in this, amongst the peers, they know who has a particular C-section rate. And so there is evidence from the literature to say that this is an effective strategy. And the next slide just highlights some of the some of the quotes from the different health professional groups about their perspective and their buy-in to this program. So the chief of obstetrics said it's important for patients to know that having a C-section is not a risk-free procedure. And one of the midwives says, knowing that the women you work with and for actually have a real shot of having their baby their way, getting someone to work with them if they've had more than one C-section, being supported to wait for labor is really something for them and also for us. And the perinatal nurses, it was also very important for them to have buy-in. They highlighted that they have increased patient satisfaction because the patients are more involved in the decisions about their care. This is commenting on the birth option session. The next slide gets into some of the strategies that were used more on a policy level, more on broader policy of the unit. And specific example here is that they updated their VBAC policy to reflect best evidence about VBACs and encouraging women to undertake the birth option sessions just to kind of walk through a decision aid and have a conversation with someone. So these are in-person birth option sessions. They also changed their policies around post-date labor inductions to ensure that they would only happen starting at 41 and 0 weeks gestation. So you couldn't even call in to book something unless you were 41 and 0, and ideally not actually booking until 41 and 3. And they noted when we spoke to the folks at Markham Stouffville Hospital that the nurses doing the booking were real champions of this. So again, everybody had skin in the game. Everyone had buy-in to the program, and that was really important because again, there are a variety of different places where one can intervene. The nurses would be really quite adamant to say, to women who would want to come in, and they would say, we really understand, that you're getting tired, but it's really important for you to wait, for your baby. And so that was really, again, very important. So the facilitating nurse booking those clients were very effective. And so if we just look at some initial findings, so in May of 2010, before they started this process, 43% of inductions were booked between 40 and 41 weeks. But in the following February, they went down to 14% of inductions were booked between 40 and 41 weeks. So our next slide just provides, a summary of those interventions, and I'll just walk through that quickly. So the first cluster there are, focusing on the patient and the different strategies undertaken there. The second cluster is on providers, and then on the units, the policy units. And so this is just a summary of the different interventions again, and what they walk through. And I apologize, this is taking a long time to get through. I'm hoping that it's not because of my screen. Sandy, is it on your screen?
Yes, we can see it, Ivy.
Okay, I can see it now. Maybe it's just my screen that's being really slow about it.
Okay.
Yeah. So again, the target in terms of the pregnant women, the patient education campaign, the prenatal classes were content was also reviewed. They updated a patient education booklet again to really support normal birth pushing. There was the audit and feedback for the healthcare practitioners, where they updated that every month, and also there was a lot more emphasis on supportive care in labor. So with women increasingly receiving one-on-one nursing care at least 80% of the time. Also at the maternity unit, again, the supportive care in labor, and just some very basic things like a desk and chair placed in every delivery room, so that encourages the nurse to stay in the room. So some physical strategies and unit policies as well in terms of the adopting the joint statement of normal birth. So the next slide just links us into the evaluation, and we can click on one more just to look at the evolution of the strategy. So this was very much this study that we were doing was very much in collaboration, so very much in the spirit of what CIHR refers to as Partnership for Health System Improvement. So it's very much a collaboration between the task force members and the researchers on our team, and I'll describe that in a moment. So with the planning grant, the next slide highlights some of the outcomes of a scoping review that we did. And that was one of the activities that we pulled together, because in preparing a grant for CIHR, you need to have a very solid literature review. And we also wanted to use this as a strategy to provide some support for the for the decisions that the task force had made or were in the process of making in terms of tweaking their multiple intervention strategy to best reflect the evidence. And so we know from the literature that individual audits and feedback are effective, so that was very supportive. We know that induction of labor prior to 41 weeks leads to further interventions such as C-section. So again, there was further evidence to support that intervention strategy. The data that we had about VBAC rates, which the task force was very well aware of, but again, we brought that, summarized that, and that women who receive midwifery care have higher rates of quote-unquote normal birth. And again, there was lots of evidence about continual support during labor and how that decreases the rate of intervention. So all of that literature that we brought together really supportive. We still had some critical knowledge gaps about whether or not shared period audits or feedback practices are effective in increasing normal birth, and how care practices can be modified to prevent induction of labor prior to 41 weeks. Even though there was data about VBACs being safe, there wasn't a lot of literature on how we could increase VBAC or trials of labor for women who've had a previous cesarean section. And it wasn't clear what particular elements of midwifery care, such as informed choice, and whether there's an indirect impact of midwifery. So we wanted to take from that literature what is it that we could translate to care from other healthcare providers, from family physicians and obstetricians. And then also just the provision of continuous labor support. Is that feasible within a community hospital with multiple care providers? So that's so we provided that review of the literature, enabling Markham Stouffville Hospital, first of all, to have confidence, to be able to say, yes, these are evidence-based interventions, for them to tweak the interventions based on what we found. And so the next set of slides that we'll go through are some promising preliminary results. And so the first slide there is looking at labor induction rates, looking at percent of births in terms of labor induction. And the very straight line through there will focus on the target. And so the purple line was what happened before. So there's fluctuations, throughout the month that one sees. But if you could see after the intervention strategy, this was very successful. They got it even below the target that they were looking for. So the green line was 2010-11, and then in 2011-12, the yellow line, again, everything was below the line. Another way to look at it on the next slide is just how they managed to reduce them, and this is where they kind of teased apart, because the last slide looked at inductions in general, but if you look at the number of post-date inductions, that really came down very, very dramatically, whether they were appropriate versus not indicated. So the purple bar they brought it right down to nearly zero, which was great. The next set of slides will look at some of the preliminary results from the birth options after cesarean section. So the first slide looks at how many trials of labor were attempted, and so before they implemented the strategy, it was at 15%. They brought that up to 29%. It came down in 11-12. And we're looking at getting the new data for 12-13. So there is an issue about sustaining it, right? So there was this big push in it in terms of 10-11, and so there's not only the rolling out of innovations, but the sustainability. The next slide highlights some of the data that we're getting from surveys that were conducted pre and post the birth option sessions with the participants, and there's some very promising data that's coming out of those surveys. Participants noted that the information that they were provided with was very useful, and it was very good for them to get all that information in one place. And the chart that's in purple is very informative because 80% of the content, over the 80% of the content was really new. So they were getting new information that was really helpful for them to be able to make their decision. They were very satisfied with the sessions as well. They really liked the instructor, and they felt that the presentations were really good. So we've provided feedback to Markham Stouffville Hospital based on those evaluations, but we're also using this to tweak the birth option sessions, particularly as we go forward. So the next slide, we'll get at just a quote from one of the women. We did ask for some qualitative data as well as quantitative data in the surveys. And it was very nice to see that they felt that it was that they were initially very scared to go through labor again. And Lee, who was the moderator for the session, they kept me informed and going safe. And once delivery was over, I couldn't believe how quick I was able to move around and start caring for my baby. That's what made me feel so much better about delivering this way. I just feel it's a safer way to deliver. So this is someone who had a successful VBAC who had attended that session. So that's really great. Now, the next set of slides is getting at really the crux of the issue, right? What's happened to the C-section rate? Because, again, if you remember back to our chart, increasing VBACs will reduce the C-section rate, or increasing trials of labor for women who've had a previous C-section, and reducing the induction rate. So here again, the target is 25%, and so there was some moderations in terms of the blue line, but in general, it was still above the target, and it's become much closer to the target with the yellow line. So the next slide is a little bit clearer in terms of looking at averages. So the purple bar is again looking at what their C-section rate was starting off in 9-10, so 29.7. They brought it down in 10-11 to 26.3, and that they've managed to achieve that 26 rate. Now they still have the target of 25%, and they're still working with that. And we'll be getting the data for 12-13 just to see how that sort of works through. But that's fairly fairly substantial with a 12-month rollout. So how this the next slide talks about how this has evolved. So these preliminary results have been presented at a variety of different conferences. There was an Association of Ontario Midwives meeting. We also presented at the Canadian Association of Midwives and also at the Ontario Hospital Association, which got some good buy-in, and that's where we connected up with Sandy and linked up and started collaborating with Bourne. And Danielle and Esther did some presentations with the Champlain Lynn Committee for Maternal Newborn Reproductive Care, so CMNRP. So the Queensway Carleton Hospital became very interested. They were having a similar types of conversations as Queensway Carleton was having. And so they decided to adopt this strategy, which we'll call the Queensway Carleton Hospital CARES, and therefore this is why we call it sort of the CARES evaluation. So the next slide is just linking into CARES evaluation 2.0, and then we can just click further and look at the CARES evaluation team. So we call it CARES now just because we want it to be translatable. We acknowledge that Markham Civil Hospital is the innovation site, and we're looking at Queensway Carleton as the adoption site. So we're very interested in this process of not only evaluating the initiative in both hospitals, but examining the process by which an innovation like this translates into another hospital. So we're very keen on this and really excited when Queensway Carleton Hospital was interested. So this just provides an overview of the team. Eileen Hutton and I are the PIs. Eileen's a midwife and more quantitatively oriented than I am. I'm more qualitatively oriented, so very interested in process and qualitative data. Sandy is on our team, Danielle Rolfe, Esther Schumacher, and as I mentioned, Elena Rishma, and Sue Eldred is another PhD candidate here at the University of Ottawa in nursing. And I'll just back up to Evelyn Forget, who's at the University of Manitoba, and she's a health economist who has provided us with a very interesting economic evaluation package. We have knowledge users at Markham Civil Hospital as well as at Queensway Carleton Hospital. Knowledge users is the term that CIHR uses in terms of how we identify folks on the project. So the next slide just highlights the first two key objectives of our evaluation. So the first there is for us to evaluate and explore. So it's evaluating both quantitatively and exploring qualitatively the cumulative effect of the MSH-CARES initiative at Markham Civil Hospital. We'll also analyze this at Queensway Carleton Hospital on the rates of intervention during childbirth without compromising health outcomes for women and newborns. So this will be a clinical outcome evaluation. And so with the preliminary results we have there, we cannot control for data about outcomes for women and newborns. So even though we may say that these results are promising, they're promising when you're only looking at the C-section rates. And some people have asked us, well, what are the intended or unintended consequences for women and newborns? And so we can't answer that as of yet with just the preliminary data that we have. So we want to do this much more extensive evaluation to control for that. We also want to do a process evaluation looking at the experiences of birthing women, their care providers, and the administrators with the intervention, because this will speak to the issue of sustainability as well. So the next slide talks about our third and fourth objectives. We want to know whether or not this initiative is economically advantageous compared to routine care. And there's a variety of different economic factors that we want to include in the evaluation, but it will look at formal funds. So we initially wanted to do, but it's a little bit more complex, and the reviewers are less comfortable with that. So we're going to be looking at formal economic evaluation, so cost of the hospital, cost of care providers, that sort of thing. So we won't be looking at, although it's very important and to consider, the costs of extra child care if women have a C-section, if they need to bring in family members, or lost time for work for family members, those kinds of knock-on effects. And then the fourth point here, looking specifically at the case of the translation or the adoption of the strategy from Markham Stouffville Hospital to Queensway Carleton. So if we look at the next slide, it's talking about sort of the clinical outcome evaluation. So we're going to be doing a quantitative assessment of the effectiveness of the MSH-CARES initiative in terms of reducing the proportion of births by C-section and the use of other interventions during labor and birth. So we'll look at the induction rates, of course. And we want to look at that in terms of different periods. So we'll have the 12 months interventions. There will be, 24 months pre. We'll look at the 12 months in terms of the rollout, because that's approximately how long it took at Markham Stouffville Hospital to roll out their initiatives, and then look at it 24 months post initiative, so both at Markham Stouffville Hospital and Queensway Carleton. We, in order to do a comparison with both hospitals, but Markham Stouffville Hospital, depending on when we get the funding and when we can get started, we might be able to do some even longer-term post-intervention at Markham Stouffville Hospital. We want to evaluate and look at those intervention rates by looking at outcomes in terms of issues around safety for mothers and babies, and we're going to be looking at the born data specifically for the two hospitals, but also looking at what might be happening in the region, because we don't anticipate that there's an overall reduction rate in C-sections in the two regions that we're looking at, but we want to take that into consideration and make sure that the findings we have for the two hospitals are really quite robust. The next slide outlines the process and economic evaluation, and we are going to do surveys both at registration and at exit that they'll be provided to all patients to assess their awareness of the strategy. So this is just next slide on the process and economic evaluation. And so because we want to see what how aware are people just in general of the strategy, both before and after they've left the unit. We want to do an evaluation of the impact, effectiveness, and accessibility of the birth options after cesarean session for those clients who are eligible. And so again, we'll do a pre-post survey. We also want to do qualitative interviews with mothers, care providers, and hospital administrators about their experiences and the cost of implementing the MSH-CARES initiative will be evaluated. And the next slide is just talking about our scale up, and I'll have a few slides that I can present in that regard. So I have about 3 more slides left, so those of you who are, I'm just going to prime you guys to get your questions ready. So scaling up is to look at how feasible and acceptable it is, and the process of translating this or adopting this innovation, and what types of modifications will be made. So we want to describe, I have a very clear description of the contextual differences between Markham and Queensway Carleton and what impact that they've had, because context really matters when you're adopting an innovation. So being the innovation site, being the adoption site, you have different, so you have a different sort of buy-in to the program. We wanted to describe what was the impetus at Queensway Carleton to adopt this particular strategy. So we've done some initial interviews about that and what they were starting to problematize and how consistent that was with the interviews and conversations that we had at Markham Stouffville Hospital about why they started that initiative, and how they're going to adapt it to meet the needs of their particular clientele. So the next slide just looks at they have started the adoption in late 2012 at Queensway Carleton, and that they have revised some of the strategies to better fit the professional and patient context or profile of Queensway Carleton Hospital. So you have a different clientele base, like they're both community hospitals, so that's been helpful to kind of keep those things somewhat constant. But at the same time, they have different client populations. So the next slide, some of the conversations that we've had. Next slide, sorry, on the healthcare professionals. So they felt that the patient information might be better put online in terms of a video. So rather than doing these in-person birth option sessions, that there would be an online birth option sessions available, that it might be a bit more amenable to their clientele to participate. So they felt that there would be greater coverage of those for the women through having that online. And what's interesting is we've set up, monthly teleconferences between our knowledge users, the folks at Queensway Carleton Hospital, Markham Stouffville Hospital, so that it enables some cross chat between them. So folks at Queensway Carleton Hospital were also interested in using a different decision aid, and so there was some conversation that we had about that. And so this was, one of the main differences that we've seen so far between Queensway Carleton and Markham Stouffville Hospital. They're currently developing some posters with content specific to the patient population in terms of ethnicity, and the issues around sort of supportive care during labor in-service training. They're taking that into consideration. The next slide is just a quote from some of the initial interviews that we've done in speaking to the issue about the different patient-provider contexts. And it speaks to the issues around, again, that context really matters, and when you're adopting or translating an innovation. And so it was important for us to highlight these types of issues because it's important for other community hospitals or other hospitals, could be teaching hospitals, that would like to adopt a similar strategy, that there can be some modification to better meet their needs. So this quote was just sort of speaking to that particular issue about the patient populations might be a little bit different, and their affluence and their level of education may mean that they would want to, have a different strategy, particularly around VBACs in terms of the format and the content and follow through with those particular strategies. So with that, that's the main content of my presentation today. My next slide just gives you a way to contact the three of us on the research team with Danielle and Esther. And so very looking forward to, comments or questions that you have about this initiative moving forward. So thank you.
Thanks so much, Ivy. That was a great overview of the project. I'll just cue everybody again, following your suggestions to be thinking about questions. You should see a little sort of a bubble place that says chat or chat box on your screen. You can type in to all attendees your question, and we'll just monitor the little box. Should be over on the left-hand side of your screen in the Tools section. So we'll just hang on for a minute, Ivy, and wait and see if we have any other questions that come in. There are none there right now.
Okay.
I'll maybe just pose a question for you, or just ask if you can comment about this, whether there will be opportunity for looking at some comparison between the hospitals, the Queensway Carleton and Markham Stouffville groups that are participating, and perhaps other hospitals that are not yet a part of the project, some sort of control comparison with other similar levels of care or volumes of birth hospital. Is there any opportunity there or plan there?
Yeah, absolutely. So I first of all want to say that if we were controlling this very directly from a researcher perspective, we would not have wanted Markham Stovall to get started on their initiative until we had the funding to kind of, really hit the field. And so we were never going to tell them to stop, and I don't think that they would have anyway. Because we wanted to make sure that we wanted to kind of have them continue with the innovations. And the same thing is that if we wanted to be really controlling, like if this was a randomized cluster trial, there would be no flexibility in what Queensway Carleton could do in terms of adopting and adopting the strategy and revising it to better reflect both their patient and professional context. And so I find that's really interesting is that process of adopting and making it much more specific to to their particular hospital. So this is not a randomized control trial, a randomized cluster trial. There may be a role for that at some point, but again, because we're interested in having some flexibility and understanding this translation and adoption process a bit more fully, which is the reason why we've taken this kind of multi-methods approach to it. So the qualitative data will be as interesting as the quantitative data to be able to say, okay, what are our hard outcomes in terms of C-sections and maternal and neonatal health outcomes. But what's also interesting is just how do you innovate, how do you emulate, and how do you sustain? Very interested in all those levels. So if other hospitals are interested in undertaking this, we'd be quite interested in why, first of all, and then how they go about doing that. I think the folks at the Ontario Ministry of Health are very interested in this project. They're very interested in this at the Ontario Hospital Association. They've provided us with letters of support, so they're very keen on supporting this. There's research initiative that's through a CIHR grant. We're hopeful that we'll get the full funding at some point, and we'd be very interested in seeing what else we could do, how we could do other projects piggybacking on this one.
That's great. Thanks, Ivy. All really excellent points. We do have one question that's come up in the box, and the question is from April, and she's asked, has there been any significant changes to the emergency cesarean section rate since starting this initiative? Have you got any numbers at all to reflect that question?
I don't have any specific numbers on that. And again, just because we have the very rough data, but we would be teasing apart the other thing that we'll be doing, which is what we're really excited in partnering with Foreign about, is being able to tease apart the different types of cesarean sections and which cesarean section rates, by the Robson criteria, which cesarean section rates are most influenced by this strategy. And I think that would be very helpful to know because, again, every hospital has access to their born data, as I understand, and so they would know their C-section rates by the Robson criteria. And then if they could see, oh, okay, we have problems with criteria, and I'm just throwing out numbers 1, 3, and 5. And if you find out from our results that this particular strategy is really helpful with those 1, 3, and 5, then that's even more helpful information for you in terms of adopting the strategies. Now, it's difficult for us to tease apart what is the effect of the patient-focused initiatives versus the provider-focused initiatives versus the hospital policy-focused initiatives. We've decided to look at the cumulative effect of the package of interventions together. It's impossible for us to tease apart which has more of an influence because it's a very complex, dynamic process, the decision to have a C-section. And then there could be a lag effect of these initiatives, right? So it could take 3 months for the provider stuff to kind of kick in. It could take 8 months for the public education campaign stuff to kick in. So it's hard for us to be able to say which is doing what. But we don't have anything specifically on the emergency C-sections at the present, but we're very interested in looking at that, specifically.
Okay, that's great. We have another question from Naomi. Who made the decision about whether induction was appropriate or not? I guess that must be specifically referring to hospital, the site-specific decision-making within the healthcare team.
Right. So there was an interdisciplinary, definitions of criteria of what would be appropriate. So that's more of a clinical decision. What's more of a policy decision is about inductions for post dates. And that's why they target their strategy quite specifically to, because you can have, a hard and fast line to say you should not be inducing only for post dates if there are no other indications until 41 and 0. But if there are any indications, any other indications, clinical indications for why you should be doing an induction, that's not considered in the category of inductions for post dates only. So it's inductions for post dates without any other indications, but any other indications would be considered appropriate. So if there are indications, that would be considered appropriate. If there are no indications, and I know that might be a gray line, and I'm not a clinician myself, but that would be a decision made by an interdisciplinary.
Okay. Naomi just added a little phrase to say in relation to the graphs, but I think that's what you just elaborated on.
Right, yeah.
So I just have another comment. I'm wondering whether will be exploration a wee bit around the hospital, the context of care in relation to, for example, whether the hospitals that participate in the projects, whether we look at things like participation in the More OB program,
right,
or other types of exposures that the hospital teams or policy changes that will perhaps have gone on concurrently with the project, and any exploratory work there that's going to be captured to help just paint the picture of what the environments are like.
No, absolutely. So that, when we do the interviews with the different participants, the providers, the hospital, we'll be asking about, so what else is happening at the hospital beyond just the elements of this initiative. And in some of the monthly conversations that we've had between the clinicians at Queensway Carleton and Markham Civil Hospital, there has been a discussion about More OB and what people are doing specifically, again, and how you're translating More OB to your context. So we are very keen on those initiatives as well. If there was a larger randomized cluster trial, which we're encouraging, and having conversations with folks at the ministry to say, this would be the logical next step is to do something like this. Then you would need to, choose your sites very cautiously, either, to have maximum variability or try to kind of cluster different hospitals that are similar together, and that would be an important contextual analysis that you would have to do. So what other initiatives are happening? Because not everybody is at the same point, right? Everyone's at different starting points in terms of focusing on this. Some people might be doing some of these things already. Some hospitals may never have booked an induction prior to 41 and 0. So that wouldn't be particularly effective strategy for them because they're already doing it. So it does really depend on where the hospitals are at initially. So we're very keen on understanding that contextual climate before the intervention happens. Absolutely.
Okay, that's great. We have another question that just popped into the box from Jessica. Hi, Jessica. Sorry, I missed the first part of the presentation, she says, but would you be looking at labor management practices as well, specifically latent phase management, augmentation practices, etc. Oh, and she adds assisted instrumental delivery.
Okay. No, those are very good points to raise. And we should be able to capture some of that information through BORN, some of like the quantitative information. But yeah, hospitals are, have different levels of supportive care during labor, sort of the one-on-one care, but also how actively or not do they manage stage 2. So that's other really helpful contextual information that we'll gather, which is separate from this initiative, absolutely. But it's part of the context, and so in order to compare the two different sites, we would need to capture that kind of information, and if other sites would be interested in participating. I'll just mention another issue that's come up in other work that I've done, which is just more broadly about the process of innovating, emulating, and sustaining particular promising practices. And what we're hoping to provide some resources is that a lot of innovation sites or pilot studies get what they refer to as pilot fatigue, because the best type of emulation or way to translate knowledge is from peer to peer, and which is the reason why we've set up these monthly conversations amongst the clinicians. We just facilitate that, but it's largely them having a conversation back and forth. We have resources to do that, whereas many other, innovative sites don't have that. So that's how they get fatigued, because they're constantly, asked to showcase what they're doing. And although that's really great and positive feedback, if there are no resources to do that, like economic resources or human resources or just, time, to do that, it's very difficult for those innovations to be showcased, for them to be scaled up, for them to be adopted by other sites. So we feel that, we have an important role in enabling that. And that's another thing that we will be including in our process evaluation, is the importance of having that that kind of knowledge broker, and the role that Sandy played in terms of linking us up with the folks at Queensway Carleton Hospital through invitations to present at CMNRP here in the Champlain-Land. All of those are important steps in terms of translating, so we're keeping track of that, but you need resources for that, absolutely.
That's great. Ivy, another question from Marilyn, or comment, I guess. She says, I thought the definition of post dates changed, not 41 and 3, but 41 and 1 as per SOGC guidelines. I know you used the numbers 41 and 3, Ivy. Can you just clarify that?
Yeah, so the initial number was 41 and 3. That's where, Queensway Carleton Hospital was initially having discussions, and how they've implemented it is that they allow you to book if you're 41 and 0. I mean, it takes some time to book. Like, it's not instantaneous when you call in. When you're 41 and 0, you're not going to get it like that day. So it might take, a few days. But my understanding of how they've implemented the post-date booking is that you cannot book until 41 and 0.
Okay, thank you for that clarification. There are no other questions in the chat box at this point. Just give it a minute. I'll perhaps just we have 2 more minutes before we do have to sign off, and I just perhaps like to make a comment about resources that BORN has developed. Certainly the BORN-Robson report that Ivy did refer to, which is now available for all authorized BORN users who have report access. It's available under the Clinical Reports tab in the BORN Information System. And underneath that, within the category of reports called Maternal Newborn Reports, there's a report called the Robson Cesarean Section Monitoring Report, and that provides every organization, every hospital, with their Cesarean section rate broken down by the Robson criteria, Robson categories, which is a really excellent starting point to get a handle on the clusters or categories of women receiving cesarean sections in your hospital, because of course, as we all know, some cesarean sections are absolutely essential, very appropriate, and should be done for mom and baby safety and well-being. And the challenge is to explore opportunities where cesarean sections could be perhaps considered in a different way, and that's what you're trying to focus on, is that problem-solving process within the different participating hospitals. So just to flag that to everybody's attention, I think probably everyone within the participating hospitals who enters born information into the born information system are all quite familiar with the fact those reports are there, but just to our broader audience, in case some people aren't familiar with that. And the other point I'd just like to make before signing off is that the born dashboard, the maternal newborn dashboard, contains a cesarean section indicator, which is the elective repeat cesarean section less than 39 weeks key performance indicator, providing information to user hospitals in an audit and feedback form to help flag, evidence practice gaps related to that indicator. So it doesn't specifically target the overall cesarean section rate, but rather is focused on the issue of timing of cesarean sections, but still related to the overall topic of cesarean section. So I just wanted to let you know, just to plant the seed and remind people about that. It is just past 1 o'clock, so I'm afraid we're going to have to sign off now. I'd like to thank Ivy for taking the time and sharing this information with us. It's been tremendous. I'm hoping the networking will increase and opportunities for those of you who are interested in finding out more information from Ivy and her team. The contact information is there on the slide, and as we said, these slides will be posted and the webinar will be posted on the born information on the Born website if you have any colleagues who might be interested in it in the future. So I'll thank Ivy, and thank you all for joining us today. Please stay tuned. We will be having a Born information rounds in May. And again, as always, we will send out our notice early in the month of May, a week or two before, to announce our speaker and topic. And I wish you a great afternoon. Hope you have a good day. Thanks for joining us. Bye now.
Thank you, Sandy.